Welcome to the deep dive. Our mission today, laser focused. We're doing a deep dive specifically for you plastic surgery residents and attendings. We're cutting through the noise to really get into perforator propeller flaps for covering those tricky middle and distal leg defects.
Yeah, and it's definitely a high-stakes topic. I mean, covering defects in the distal leg, that's a major challenge. There's just not much soft tissue down there. And propeller flaps, well, they offer a really critical local alternative before you immediately jump to considering a free flap.
Right. And the big payoff right up front is achieving that like-with-like coverage. You get tissue that matches the area,
Exactly.
and you get to preserve the muscle, preserve the main vessels. So, okay, let's really unpack this. So when we talk about these middle and distal leg defects, it's tough territory. You've got bony prominences, not a lot of padding.
Very little wiggle room.
Yeah, and the biomechanics are demanding. Traditional local options, they often fall short or they're just too damaging. I mean, we look back at something like the cross-legged flap.
Oh, yeah, history.
Right. It worked, technically, but the donor site morbidity was high, and that long immobilization, it's just not something we really do much anymore.
Not routinely, no. It really comes down to a careful calculation when you see the patient. You're weighing the wound size, its exact location, is it contaminated, what functions do they need back, and maybe most importantly, how much damage you're doing at the donor site. Free flaps are often the gold standard for big, complex defects, but
they're a big operation.
They are. And the evolution of these perforator-based flaps, like the propeller, has given us this fantastic local options, really changed the game.
Okay, so the name propeller obviously suggests rotation. For the residents listening, what's the specific definition? What makes it different from just any perforator flap?
Good question. The key definition, building on Hakasoku's work, but really refined by Tio, is this. It's an island flap, longer than it is wide. And it rotates, sometimes up to 180 degrees, around its central axis. But crucially, it's based on one single perforating vessel that has been completely skeletonized, fully released.
Fully released. That release is what allows that pivot, that propeller motion.
Exactly. That's the defining feature.
And thinking clinically, this offers some pretty compelling advantages when you're counseling a patient, especially comparing it to jumping straight to a free flap.
Oh, absolutely. The benefits are, well, they're pretty clear. First, you save the main artery, you save the muscle underneath. Functionally, that's huge.
Huge.
Second, no microsurgical anastomosis. That means less complexity, shorter OR time, and you avoid a whole specific set of potential complications.
Big relief for everyone involved.
Definitely. Third, you get that like-with-like tissue match, naturally thickness, texture, color, just looks and feels right. And finally, the anatomy is on our side here. The lower leg has something like 93 documented perforators from 21 different source vessel territories. So you have options, real versatility in planning.
Okay, so that versatility hinges entirely on finding the right perforator. This brings us to planning super critical for clinical practice and definitely high yield for board prep. Success really starts here, doesn't it?
It absolutely does. This is where you prevent problems later. And it starts with the handheld Doppler, non-negotiable tool.
Right.
The sources mention an 8 megahertz probe, which is standard. But here's the real technical pearl. The angle you hold the transducer. It needs to be about 45 degrees relative to the skin surface.
Okay, 45 degrees. Why specifically that angle? What are we trying to avoid by not holding it, say, parallel?
Great question. You're trying to avoid accidentally picking up the signal from the main axial vessel running deep, instead of the smaller perforator branching off it and coming up towards the skin. If you hold it parallel, you might just hear that loud, booming signal from the main artery or vein. That 45-degree angle helps you isolate the sound of that specific smaller vessel piercing the fascia. That's the one you need.
Ah, okay, so you're differentiating the feeder from the main highway.
Precisely. Getting that right, honestly, probably saves a lot of flaps from trouble, especially early in your training. I bet that detail alone is worth remembering.
Definitely. Okay, so we've found our perforator, marked it. Now, walk us through designing the flap dimensions. How do we use that pivot point to plan the skin island? Another good board review sequence here.
Right. So the perforator is your center point, your pivot. First step. Measure the distance from that perforator mark down to the furthest edge, the distal edge of the defect you need to cover.
Got it.
Then you take that exact measurement and transpose it proximally from the perforator along the line of the main vessel axis. And here's the safety margin. You add 1 centimeter to that transposed length. That point becomes the proximal extent of your flap design.
Add 1 centimeter. Okay, building in a little buffer, proximally. Smart. What about the width?
For the width, you measure the width of the actual defect. Then you add 0.5 centimeters, half a centimeter, to that measurement.
Okay.
That little bit extra accounts for the tissue contracting a bit, and it helps make sure you can inset the flap without tension after you rotate it.
Makes sense.
And one last crucial point on design. The sides of the flap, the lateral dimensions, need to be roughly equidistant from that central axis line running through the perforator. If it's lopsided,
You'll pull on the pedicle unevenly when you rotate.
exactly, you put sideways traction on that delicate little perforator pedicle during rotation and closure, and that can compromise its flow. So symmetry matters.
All right, the planet is solid. Now we're in the OR. Patient's supine, tourniquets ready, usually set around 250 millimeters of mercury. What's the very first sort of critical maneuver before dissection really begins?
Okay, before you even make the incision, there's this neat little vascular check you can do. You find the popliteal artery behind the knee and just apply digital pressure for about a minute.
Okay.
Importantly, you do this without having exsanguinated the leg first with an Esmarch bandage. You want to see the baseline flow pattern.
Ah, so it's like a quick real-time check of the baseline perfusion, confirming your Doppler findings.
Exactly. It gives you a little snapshot before you commit to the dissection. Okay.
Yeah.
Now, for the dissection itself, do we go above or below the fascia?
Mm-hmm.
You can actually do either subfascial or superfascial. It often depends on the tissue quality, how deep the perforator is. But the key is maintaining that axial orientation, following the vessel's path.
Yeah.
And the single most critical part of the isolation phase.
Yeah.
You must dissect the pedicle out for a length of at least 2 centimeters. 2 centimeter minimum.
2 centimeters.
Yes. And during that dissection, you have to meticulously divide any small muscular branches, release any fascial bands or adhesions tethering it. That 2 centimeter length is usually what gives you the freedom to rotate without kinking or stretching the pedicle.
Okay, that meticulous 2 centimeter release is done. Now, the moment of truth. How do we confirm the flap is actually viable before we swing it into place? This feels like the point of no return.
It really is.
Yeah.
This is the perfusion check. So dissection's done, you release the tourniquet, let the blood flow back in. Then you just wait. You leave the flap sitting in its original bed for a full 10 minutes.
10 minutes. Patience is key.
Crucial. You're watching carefully for capillary refill. You want to see that nice, brisk pink up all the way to the edges of the flap.
And what if you found more than one decent-looking perforator during the dissection?
Good point. If you identified, say, 2 potential candidates, now is the time to test them. You take a micro clamp, like a small bulldog clamp, and temporarily occlude one of them. You need to definitively confirm that your flap is surviving based on one single perforator island. That's what enables the full 180-degree rotation if needed.
Which, according to the study, was possible in a lot of cases, right?
Yeah, 82% of the cases reviewed achieve that full 180-degree rotation, which just speaks to the versatility when you isolate that single perforator properly.
Speaking of cases, let's pivot to the results from the study this is based on. They looked at 28 patients, average age pretty young, 32, mostly trauma causing the defects. What did the data show about how well these flaps actually work in practice?
Right, looking at the numbers, what's interesting is which perforator vessels were most commonly used. The posterior tibial artery, the PTA, was the workhorse used in half the cases, 14 out of 28.
50%. Okay.
Then the anterior tibial artery, the ATA, was next at about 39%, so 11 cases. And the peroneal artery, PA, was used less often, around 11%, just 3 cases. And the average flap size was 48 square centimeters, which is actually pretty close to the theoretical maximum area thought to be supplied by a single perforator of average size. So these weren't tiny flaps.
No, definitely pushing the limits there. Okay, the crucial part for resident learning and patient consent. Complications. What was the rate and what kind of issues came up?
The overall complication rate reported was 14%. That's 4 patients out of the 28, which, sounds pretty reasonable for this kind of surgery.
14%. What were the specific problems?
3 of those 4 were partial flap necrosis, meaning less than 15% of the flap area died back. And 1 case was just superficial epidermolysis, like a blistering of the top skin layer.
Okay, manageable issues mostly. Was there any pattern to the partial necrosis cases?
Yes, and this is a really interesting clinical point. All 3 cases of partial necrosis occurred in flaps based on the posterior tibial artery perforators.
All 3 on the PTA.
All 3. Now, this particular study, with only 28 patients, that finding didn't reach statistical significance purely based on the artery choice. But it's a strong clinical signal, right? Something you definitely keep in the back of your mind when you're choosing between potential PTA or ATA perforators.
Absolutely. Any thoughts on why the PTA might be associated with that? Scar tissue in the back? Venous issues?
It's probably, like you said, multifactorial. Could be related to the typical trauma patterns affecting the posterior compartment more, leading to more scar. Maybe something about the venous drainage, the vena comitantes being more delicate back there. It's hard to say definitively from this data alone.
But important context here is how this 14% rate stacks up overall.
Exactly. When you look at bigger meta-analyses of propeller flaps, the reported complication rates can be higher, sometimes around 25 or 26%.
Wow, okay.
And importantly, the risk of total flap loss with propeller flaps is generally very low, often cited around 1%, maybe slightly higher. Compare that to free flaps, where total loss rates can unfortunately range anywhere from 4% up to, in some series, almost 19%. That's a big difference in risk profile.
That is a significant difference. And what about the donor site? How often could they close it directly?
That's another win for this technique. Primary closure of the donor site was achieved in almost 86% of cases. So usually no need for a skin graft there.
That's excellent. Now, there was one other statistical flag that popped up related to patient sex.
Yes, this was quite interesting, though again, small numbers, so interpret with caution. Female patients in this cohort actually had complications in almost 43% of their cases.
43% compared to the overall 14%.
Right. It suggested a trend towards statistical significance with a p-value of 0.038. The authors hypothesized it might be related to hormonal effects influencing the venous system, or maybe differences in skin quality or subcutaneous fat-making dissection or closure are trickier.
Something to consider.
Definitely a point that warrants maybe a bit more caution or specific discussion during preoperative counseling for female patients undergoing this procedure. Hashtag outro. So, wrapping things up, I think the evidence presented here is pretty robust. The perforator propeller flap, when planned and executed carefully, is a really reliable, safe option for these small to medium-sized defects in the tricky middle and distal leg. You get stable coverage, the tissue match is excellent, both functionally and aesthetically, and the donor site morbidity is impressively low most of the time.
Yeah, and the main takeaway, I think, for anyone doing these or learning them is that the technical steps just aren't negotiable. That meticulous dissection, getting that minimum 2-centimeter pedicle length.
Absolutely.
And that rigorous preoperative Doppler mapping, using that specific 45-degree angle to really find the right perforator, confirming it's a single vessel island. Success really hinges on those details.
Couldn't agree more. And, thinking about those few cases of partial necrosis, often that can be linked back to including scar tissue in the flap or maybe trying too hard to close the donor site directly, creating excessive tension.
Right.
So that brings up a really interesting, maybe provocative question for you to consider in your own practice. When you're planning one of these flaps, where's the tipping point? At what point should you maybe back off trying to force that primary donor site closure and instead accept putting a small split-thickness skin graft there if it means ensuring better perfusion and easier rotation for the propeller flap itself?
That's a great point. Trading off a bit of donor site aesthetics for potentially better flap survival and function.
Exactly. That balance between local aesthetics and flap viability. It's a critical judgment call you have to make every single time. Something definitely worth thinking about.